they're probably the biggest innovations in the treatment of depression in 7 decades. And people get better. They get better within 1 day.
Hi, I'm Eric Bombicino, and today we're going to be talking about ketamine. Now, ketamine, once known as a party drug, is being used widely to treat depression, including treatment-resistant depression. Now, that will be, I guess, our villain for today's interview. What is treatment-resistant depression? Why do depressions such as this take such firm root in people? And how is ketamine being used to treat it? And how effective is it? I want to welcome Roger McIntyre. Thank you for coming. You are a professor of psychiatry and pharmacology at University of Toronto. You are the chairman and exec director of the Brain and Cognition Discovery Foundation, and you have about 48 other titles that we will reveal later, but thank you for coming.
Thanks for having me, Eric. I'm looking forward to our conversation.
All right, let's get into it. So we're going to be talking about ketamine.
Yeah, you bet.
And using it for treatment-resistant depression, but we should probably define our enemy. I guess our villain of this interview is going to be treatment-resistant depression. So how do we define it?
I love the way you said that. It's a villain, because in my view, this is probably the greatest scourge to humanity. In fact, the literature shows that's the case. And, you know, having depression is not just a burden on the person living, but it's also a tremendous cost to our society. The FDA in the United States has the definition that's been most cited. And that definition is someone who has depression, they have lived experience, they've been taking 2 or more antidepressants for an adequate dose, an adequate duration of time, and they've been taking it. And if after 2 or more, but minimum 2 trials, they're still struggling, the FDA says, we think you've got treatment-resistant depression. But the FDA is also very quick to say they recognize that this definition is not totally arbitrary, but it's not the only definition that's out there. And there are many aspects to that definition that fall short of ideal.
Should we change the definition of it? Should we rename treatment-resistant depression or rethink the term?
I think nothing speaks louder than an example to answer your question. I saw this gentleman, and he came up to me at my clinic. This was just before the pandemic. And he came up to me and he said, can I speak with you for a moment? I said, sure. He said, I've been struggling with depression for more than a decade. He had listed many treatments he'd been on, which were very conventional approaches, including electroconvulsive therapy or shock therapy.
Which we'll get to later.
And talk therapy. And he came and he said, I've been told for over a decade I've got treatment-resistant depression. I said, okay. And I've come and I've been taking treatment. I've had ketamine. I'm much better. I'm back to work. He drives a truck. I'm driving a truck again. I said, this is an amazing story. It was awesome to hear this. And I didn't know where it was quite going. He goes, but can I ask you a question? So I'm going to meet my doctor like next week. And I said, yeah. Do I still have treatment-resistant depression?
Right.
And I thought, what a great question. And so I don't think it's ideal. First of all, treatment-resistant depression has a sort of a defeatist kind of sound to it. It sounds like it's the end of the line if I mean treatment-resistant. Second is that we don't know if it's actually resistant.
Right.
In the sense that there are many people who've been told they have this who get, my gentleman with point in fact.
Yeah.
And he was told there's no hope for him.
Yeah, and label matters. Labels matter.
Labels matter.
Yeah.
And then thirdly, I think there's probably, among many limitations of that definition, what if somebody, in fact, tried another modality of therapy, psychotherapy or something else, and they got better? So the definition is too medication-centric in that regard.
What should we change it to?
I think that there's a phrase called difficult to treat depression. I like it because, first of all, I think it's non-judgmental, intentionally or unintentionally. I think it's kind of agnostic.
Yeah.
Second is, I don't think it has a valence of hopelessness and defeat.
Yes.
It's difficult to treat. I mean, let's face it, some diabetic situations are more difficult than others. Some overweight situations, some heart disease are more difficult to treat than others. But we can treat you. We don't know the future. Some people can get better, and some people can get better on some very innovative new therapies. So I think I like the phrase difficult to treat depression.
Yeah, no, depression is a liar. Depression can distort your sense of hope. So for someone who is leaving a psychiatrist's office with the diagnosis of treatment-resistant depression, does that kind of lean into the lie that depression tells, that there might be no hope for you?
Well, first of all, I like what you just said, and I agree with that. I want to amplify that. I agree that depression is a lie, because I think in many cases it is not a infinite illness. This is not a lifetime curse. It can get better. We can't predict the future. I think it was Yogi Berra said predictions are difficult, especially when the future.
The great philosopher, Yogi Berra.
He was. But in depression, for me, I've seen patients for almost 30 years, Eric, and with difficult to treat depression and bipolar disorder, and they get better.
Right.
And I've had people say, you know, Dr. McIntyre, I've been told there's no hope for me. I've tried everything, nothing works, and so on and so forth. I would like to say we found a solution for every single person. I'd like to tell you that, and one day I hope we can say that. But what I can say is we find a solution for a lot of people, the great majority of people. Perseverance and keep pushing along and just trying to find that right match. But you're right, it is a lie. And I think when people are told they got treatment-resistant depression, I can't imagine how discouraging that sounds. Right. I think hope is critical. And I think this is a big part of why names and words matter. That's why I like difficult to treat better.
Yeah, and you've been at this for what, 30 years now?
Almost, yeah.
Those folks you've worked with these, and we'll go with difficult to treat depression, with these difficult to treat depressions.
Yeah.
Do you have a sense of who is more likely to get better and get over the wall and who might not? Do you have any idea of that?
I don't. How's that for an answer?
Yeah, so it still remains a bit of a mystery.
It's a complete mystery. And I'd like to sit here and say, guess what, Eric? We got it figured out. I can tell by the color of your shirt. I can tell by, this part of your hip,
biomarker,
a biomarker, an MRI scan, a blood test. I can then make a determination, maybe your sibling or your parent or what have you. Now, stay tuned. The future will, I think, get us over that wall. The future will be about these personalized, very precise ways of prognosticating not only your illness in the future, but also what is the right treatment for your particular condition. It remains aspirational, but it's not quixotic. It's not some fantasy. It's actually within grasp. In the near term, we don't.
Right.
And that's both the reason why we have to remain so open-minded and aspirational, but frankly, it's also what makes it very frustrating because it's a bit of a trial and error process, and that's obviously not something that's ideal.
So the mystery remains for now, to a certain degree.
For now.
But let's spend some time here before we talk about ketamine, trying to unravel that mystery just a little bit. So when it comes to these difficult to treat depressions, let's start with someone's social or economic background. How does that factor in?
It's one of the major factors.
Okay.
So I'm a psychiatrist who has dedicated my career to providing care in research in depression and bipolar, and I'm a pharmacologist, so I'm looking at new drug treatments, and that's recognized as many ways to treat depression, but that's what I focus on. And what I would say is, I tell audiences this all over the world, is that one of the most robust determinants of whether you end up with difficult to treat depression and or whether the treatments actually work is, do you have money in the bank? So precariousness or insecurity of finance, of housing, of healthcare, of food. It's hard for your treatments to work. It's hard to actually be on all cylinders when you have all this insecurity in your life.
Right.
Having security is antidepressant, it's resiliency enhancement. The other part is, and we know this from Dr. Vivek Murthy, former Surgeon General of the United States, he really, I think, brought our attention to the loneliness pandemic.
Yes.
There's a loneliness pandemic in this world, and there's no doubt about that in my mind. So when people are socially disconnected with insecurity, and one or more of the areas I talked about, that is a predecessor, not for all people, but for many people then to be on a course of a more difficult to treat depression. People have to be socially connected. If we can socially connect people, and we can reduce the insecurity in those areas we talked about, I think it's some of the most potent antidepressant steps getting people towards recovery.
The issue, though, is when you are feeling depressed, you naturally isolate, which can make you feel worse and moves you away from any opportunities to do that.
Yeah, absolutely does. And you touched on a very sensitive point, because one of the features of depression that's a core feature, a defining feature, we in the business call it anhedonia, which just simply means the absence of pleasure. It was coined by a French psychologist way back in 1896, a long time ago. And it really is just feeling blah. People are disengaged, disinterested, no joy, nothing to look forward to. And what our research has shown is not only what you just spoke to, sort of interpersonal loss of interest, not only is that common, but it's one of the most powerful predictors of suicide. When someone has lost a futuristic sort of view, not looking forward to the future, and when that collides with interpersonal anhedonia, Eric, that's a combustible mix.
I want to pause on that for just a second before we move on to other things that can inform and create these difficult to treat depressions. But I think it's really easy for someone who hasn't been depressed to see depression as an extreme form of sadness. They felt sad, so ratchet that up. That's what depression must be. And it's really maybe better to see it as the complete absence of feeling. I've had people tell me when they've come out of a depression that sadness felt like a gift. that they could feel again. They'd been sort of living with the whole spectrum of their emotions being unplugged from the wall. Is that an important thing to lay down here for someone trying to understand just what depression is?
It is, because over the years, just when I've met so many people, I've such a privilege hearing their story. What you just hit on is, in fact, the essence of depression. They've lost the basic them. They don't feel any emotion. They don't feel the usual executive control over their emotion. They can't even feel anything.
Right.
And I've asked patients for years, do you feel depressed? I don't feel anything. And
Yeah.
now, not to get too lost in sort of glossary, but psychiatry loves glossary. We have this big, massive psychiatry glossary. And there's a term called alexithymia, which Peter Sifnios coined many years ago. And alexithymia refers to the inability to name your emotion, called emotional blindness.
Yeah.
It's very common in depression. They can't even name it. They don't even know the source of it, can't even name it. So the difficulty with even experiencing anything and or an emotional blunting. People are so blunted, indifferent to everything, and or they just feel nothing but negativity. So this is all sort of happening. Each person's different, and you get a combination of this inability to experience emotion, nothing but blunting day in, day out, and or this negativistic emotional state that's just agonizing, which is accompanied by this rumination that just, it's like just locks you in this sort of checkmate situation of just negativistic, anxiety producing, very dour kind of themes. That is what I hear day in, day out.
And when it comes to childhood trauma,
Big topic.
what does let's start slow. What does childhood trauma do to someone that can later lead to these difficult to treat depressions that feel really ingrained in them?
Yeah, one of the most reproducible factors that we've uncovered with respect to folks who have struggled with response to conventional antidepressants with their depression is a history of trauma.
Right.
Now, trauma can be at any time in their life, as a child or as an adult, but childhood trauma, maybe not surprising, is especially hazardous. That's a time, obviously, with interpersonal development, cognitive development, educational attainment. It affects that, but also affects the developing neurobiology of the brain. And the developing neurobiology pursues a fairly predictable course and trajectory. And when you have a trauma event, especially when it's a repetitive trauma event, especially when it's from people who are close to you, caretakers, parents, and so on, it creates what I call a cascade event. You've ignited a whole set of biological events that cascade, causing an off-trajectory development of your brain. Your brain is literally different at age 25 when compared to someone who's 25 who didn't have trauma. And we can trace it back to the effect of the abnormal stress response created by the trauma that saved you in the short term. You see, stress responses, Eric, they save us in the near term. They get us past the stressor, but they leave a bit of sort of friendly fire, so to speak, and you've actually altered the trajectory off course. And this is very, very common in people who have depression. It becomes difficult to treat.
Yeah, so can you draw a line between that feeling people have when they're very depressed of being not feeling anything, of feeling like their emotions are unplugged from the wall? Can you draw a line between that and childhood trauma?
You sure can. And so what you touched on is such a critical and subtle point. So what often will happen, someone will have a history of trauma in youth or as a child, and what will happen is they may not have a medical diagnosis of major depressive disorder.
Okay.
But in retrospect, as a 25-year-old or 30-year-old now in their adult life, they look back and they'll say, you know something, throughout my high school years, I was really just blunted. I was just sort of passive. I was indifferent to everything. Nothing made me happy. Nothing made me cry. I had this indifference. And I started to notice that I just was disengaged interpersonally, socially. I just couldn't seem to have any kind of sort of motivation. And that's often rooted in the trauma. What happens, among other things, Eric, is that when you have a trauma event, the cascade of events changes parts of the brain that are responsible for you and I to be able to think, and also for you and I to experience emotion, because the brain is trying to protect you from the harm, the external harm, and it's compromised the normal emotional development and emotional regulation and the cognitive development. And as a consequence, people say, I think I got ADHD, I can't focus, I can't pay attention, I find that I'm moody when I don't want to be moody. I'm not even sure what's going on with me, and I don't even need a trigger. I'm kind of moody with people. And that's a loss of the chief executive officer, the brain, the cognition, over the emotional center. And that's triggered predictably at a very high rate in people with trauma. And then to add further compound to this, Eric, what happens is when you and I are exposed to stress, the body doesn't know any different. The body mounts a stress response.
As if you're a kid again.
As
you're
a kid.
almost traveling back in time.
Absolutely. And then what happens is then people then start noticing they're eating more. They start gaining weight. So along with depression, then you have obesity, type 2 diabetes, you have heart disease. And this is a very common collection of disorders that accompany depression in general, but especially when someone reports trauma.
So yeah, to put a maybe too neat and tidy of a narrative around it, you are a kid in a chaotic environment.
Yeah.
You don't know maybe when you're going to be cared for, and when you're not, what you're going to receive. It's chaotic, it's stressful, it's painful.
Yeah.
And so there is that defense mechanism you talked about, where you unplug. You don't feel any of the bad.
No.
Unfortunately, you don't feel any of the good emotions. You feel nothing. That helps you survive at a young age. And then when you flash forward to when you're an adult, it's the same response. So that defense mechanism that helped you survive as a kid is what becomes your depression when you're an adult?
In many ways, that's true. In many ways, what's happening is that when you are traumatized as a child or as a young person, in addition to affecting the brain's architecture and its overall function, what's happening is that the brain's stress responses become super sensitized. And so when you're a late teenager, early 20s, you're a bit more sensitive now to stressors that happen. And a lot of people go on to even have concurrent post-traumatic stress along with depression. But most people with depression don't have PTSD. But the phenomenon's similar. And so when they're exposed to a stressful event, their system becomes overwhelmed because the stressors as childhood hasn't provided for them the environment to mature, to grow and have full executive control over the stress response. So what seems to be a relatively manageable stressor as an adult for them becomes unmanageable and then triggers this negativistic mood state, this thinking state, and other symptoms of depression like loss of appetite and sleep and so on.
So there's trauma, but there's also genetics.
Yeah.
And you often hear that mental illness can run in families.
It sure does.
And I think people might think that's a genetic picture versus a trauma one. Yeah, let's go in slow here for genes. Where does genetics factor in terms of predisposing someone to these more difficult to treat depressions?
It's such a great question, just to provide a bit of a benchmark. So there's no question that there is a genetic contribution to many serious mental illnesses. We, in fact, are still, frankly, if I could use a Netflix sort of metaphor, we're still in episode 1, season 1, maybe episode 2, season 1 of
what's
genetics.
The show?
The show is called Unraveling the Mystery of this situation called mental illness.
It's a long title, but
it's a long title. I got to get a more of a kind of a catchier kind of bumper sticker title, but that's the gist of it. In schizophrenia, in bipolar disorder, in ADHD, the genetic risk has been estimated to be at about 75 to 90%, even higher. All that means, translated, is the vulnerability to the condition is clearly very genetic. There's an environmental component as well, and this has been arrived at by looking at twin studies, monozygotic, dizygotic, family studies, this type of thing.
What do those mean? Mono and...
So identical twins, fraternal twins, if one sibling has the condition, does the other sibling have? And very smart geneticists and mathematicians can work out the genetic contribution to the mental illness. And they land on 75 to 90%-ish. In depression, on the average, let's say, Roger, time for your exam, oral exam, what's the genetic liability to depression? I would say, well, it's about 40% or so. And then what's it for difficult to treat depression? Probably closer to 50 to 60%. So that gives us at least a hint that there's something about this difficult to treat depression that may be a little different than the depressions that are responding to your Prozac type drugs. And trauma is an environmental event, but let's not forget that trauma affects the genetics.
Yes, okay, that's what I was, we easily get stuck into an either or.
Correct.
Is the better way of looking at this that there's some folks genetically that are more susceptible and sensitive to what happens in their environment.
100%.
Almost like they're more of a slightly warmed up piece of clay.
Absolutely.
Where whatever happens to them can sink in a little bit deeper.
It is, and there's also what's called, now we're seeing this data come out in psychiatry where if the parent has been subjected to trauma in their lifetime, the vulnerability to an abnormal stress response could be transmitted to the child. So you could get this almost transgenerational passing of what is an abnormal stress response.
That's epigenetics?
That's epigenetically related. Now, when someone has depression begin very young in life, that also increases the likelihood there's a genetic contribution. But keep in mind that, as you said, it's hard to disambiguate what's the genetic, what's the environment here, because often the environment could be one of, let's say, economic insecurity, living in a high crime neighborhood or a poverty-ridden neighborhood. Maybe you live in a food desert. There's no good food for 10, 20, 30 miles around. So you have malnutrition, this type of thing. So all these factors tend to cluster. But taken together, treatment-resistant depression seems to have a higher genetic loading to it, which tells us that maybe there's something about this particular entity, at least, that is different than depression that is quite responsive to fluoxetine or Prozac type drugs.
Right, right. Okay, I think now is a perfect time.
Okay.
We teased it at the top.
Okay.
I think we can talk about ketamine.
Yeah.
And esketamine.
Yeah,
so, sure. I mean, we should go in slowly here. What are they?
Well, they're probably the biggest innovations in the treatment of depression in 7 decades. It's an incredible history. A person named Carl Ritthausen in 1866, and he was looking at wheat gluten, and he found this amino acid in the wheat gluten. He called it glutamate, after gluten. And later, in the 1980s, so 100 years later, it was discovered that this is playing a key role in the brain's ability to function. We call it plasticity. So if you and I go to the gym, you go to the gym quite a bit, Eric. If you lift weights, your muscles get bigger. That's muscle plasticity. Your muscles are responding to the environmental load. Well, brain plasticity is similar. The neurons, the brain cells, they react to the environment, and glutamate plays a critical role. We always say that brain cells that fire together wire together.
Right.
And the neurons in your brain are connected. I call it CNN, just like circuits, nodes, and networks in your brain. So just a group of networks and circuits in your brain. And glutamate is what keeps them all functioning together. Okay, you get your motherboard on your computer. It's just like what your brain is. For it to work, you need to have glutamate. They discovered this in 1866, but what ketamine and esketamine does is they target that particular neurotransmitter. And so for many people who've had depression that's been going on for years, my gentleman I mentioned earlier, hasn't benefited from the more conventional approaches, this treatment just shows up on our lap 25 years ago in the year 2000. It was first studied, shown to be not just effective in some very difficult to treat situations, but rapidly so. So you go to the airport, you got the regular lineup, you got the fast track. It's a fast track. Can you imagine going to the emergency room with a migraine headache? The staff say, oh, we get a treatment for your migraine headache. It takes 6 weeks to work. You'd say, this is outrageous. But that's what we tell people with depression. Wait 6 weeks for it to work. That is outrageous. And so the advantage of not only targeting this new system is that it's targeting a key mechanism in the brain that we implicate in the process. And people get better. They get better within 1 day.
What? It's a single dose.
In some cases, within 1 day. In fact, the U.S. FDA recognizes that esketamine, which is sort of the sister drug of ketamine, is one that is rapid acting, which means it works within a week. You know what the most important thing is? People say to me, Roger, does it work in everybody? No, I wish it did. How many people does it work in out of 100? I would say meaningfully, 20 to 50%. Oh, that's not. They said that's not 100%. I said, yeah, true, we're getting there. But you know what it does? It gives people hope, and that's not measurable. That's not measurable. And the agony that I have seen in 30 years, the hope that it gives, that's not measurable. So I don't think we're in a position as clinicians to rate that, because that's not something we can't be so arrogant. And I think that is an enormous offering of the treatment.
I did want to say, bust out a little stat here, so you can have a sip of water and hop in for a sec. So there was one study that showed, and this is for folks with major depressive disorder when it comes to antidepressants. And this is folks that had a history of trauma between the ages of 4 and 7. Only 16% achieved remission after 8 weeks of treatment with 3 different types of common antidepressants. I cannot pronounce them, and I will not. We can maybe try later. Compared to 84% of individuals with no history of childhood trauma. That's a big gap.
Yeah.
When it comes to ketamine, are we seeing a similar gap like that, or is it working for folks with childhood trauma?
What a great question. That's the iSpot-D trial. It's a very important trial in the United States, and that really hits home the point that in depression there are a series of symptoms that make the diagnosis, and we're talking about trauma. And trauma is a historical event that just seems to be setting the stage for a very disappointing outcome in depression, at least with the Prozac-type drugs. It turns out that's not the case with drugs like ketamine, esketamine. They seem to work as well, in fact, maybe even better. I can't say that with confidence, but I can say they work as well, which is amazing, in people who have depression and trauma as they do in people with depression and no trauma. And we've been trying to figure out what is the mechanism of that. And people would know ketamine is an anesthetic, it's being used for pain management, we use it as an antidepressant. But the other part about this, Eric, which is really interesting, and that is that ketamine's also an anti-inflammatory. And that's not well known, but it's true. It's a potent anti-inflammatory. People say, what, like aspirin or like ibuprofen, like that? Well, sort of, yes, but sort of not the same, but it's an anti-inflammatory. And when you have trauma, what happens is your body mounts a stress response. And among other friendly fires, trauma creates a pro-inflammation in your brain. It increases inflammation in your brain. And that's what makes you feel so tired. That's what makes you feel so...
It's like a sickness response.
Like a sickness syndrome. And we've all had, common colds, COVID. Everyone knows what that feels like. You feel blah, you lost your motivation, your interest, your desire, you can't sleep, no appetite. That's called sickness syndrome. That's inflammation. And ketamine reduces it. And so we don't think that's the only mechanism, but there's an academic interest in this question that maybe ketamine is so potent in people with a history of trauma because it's anti-inflammatory.
In terms of the experience, I've got a great quote here. One patient described it as, this was after a series of ketamine sessions, as not a temporary change, but a shift in who I am, how I approach the world, and my feelings towards my own emotions. Can you relate to that with some of the patients you've worked with?
I can, and when I first heard patients describing this to me quite some time ago, this is what really incentivized me to bring this treatment to patients here, in the sense that I heard patients, first of all, describe hope again. They weren't suicidal, and they described very much what you just described. And there's been a real effort to look under the hood, so to speak, to look at the brain, what's going on here, who are reporting this. And what we see is something truly fascinating. When you give a single treatment of ketamine, you see immediate effects in the brain. The networks of the brain, the circuits of the brain, they immediately begin to change. Now, these changes we also see with the old-fashioned antidepressants, the Prozac-type drugs, but those effects take 4 to 6 weeks to happen. And this is happening right away. But in contradistinction to the Prozac-type drugs, we're also seeing effects in the brain where those Prozac drugs don't really work so well. And what the Prozac drugs are not as good at is making you feel more motivated, more interested, more engaged with yourself, a sense of completeness and coherent and cohesive. In these drugs, the ketamine, the esketamines, are immediately giving you this sense of reintegration again, which is interesting because the subjective report maps onto what we're seeing in our MRI scans, that the brain's looking more integrated.
Are they thinking less?
They are putting less effort into thinking, but they get more efficient. There's a certain efficiency. So if you can imagine, I used to use the example of Ginger Rogers and Fred Astaire. And then people say, that's too old, they're too old. You got to use a newer, maybe Travis Kelce and, Taylor Swift.
Let's go with Ginger Rogers and Fred Astaire.
I like Ginger Rogers, Fred Astaire.
One of the great dancers of all time.
And I've always said...
We can put in a clip right now of Fred Astaire, and then we'll come back to you.
I've always said that the best metaphor for me, when you look at the brain in an MRI scanner, it really is fascinating. You see the circuits, and it's like Ginger Rogers and Fred, they're dancing together, and they're in a certain reciprocity with each other. They're just perfectly dancing. And when you have depression, it's like watching Dancing with the Stars. They're not stars. They're not in kilter here. And when you treat them with ketamine, esketamine, then you see the Ginger Rogers, Fred Astaire come back. And patients say, wow, I'm feeling like myself again. I feel my emotion again, and I can feel like normal again.
Like in balance.
And so and that's a highly replicated finding, that you have this effect on the brain circuits and the networks immediately in key regions that are relevant to us to feel, to think, and behave.
There's another analogy I wanted to throw out. I love your Fred Astaire and Ginger Rogers.
I used it before.
I'm gonna look them up after this.
Well, I
That
used it
can bet
before.
you,
One
yeah.
of my students said, "Who's that?" I felt like a fossil. I said, "Oh my gosh."
It is. I mean, it's probably, we're not going to be able to use the video of it, but it would be in black and white. The other analogy I've heard, and this is for psilocybin, which is the active ingredient in magic mushrooms, is like a ski hill. So you can get the ski tracks in the hill are your thoughts. And sometimes people can get deeply grooved into these toxic, looping, ruminative thoughts that it's all you're thinking about. You're locked in. And what psilocybin, and I'm curious if this is true for ketamine, is it basically puts down a fresh coat of snow so you can get out of those thoughts. Is that a helpful way of trying to understand what ketamine is offering people?
Well, I think that's a fair way of putting it. And you're right to also even bring psilocybin into the conversation. And I think psilocybin is still in the early innings of the ball game here. But it's ketamine has gotten over the wall. It's been shown to work. Esketamine's gotten over the wall, shown to work. Psilocybin, again, is still in development. But it's exactly right. And see, for us as human beings, what we're able to do is we are able to select, we're able to sequence, we're able to inhibit, we're able to modify how we feel, how we think, and how we behave. And when you're depressed, you lose that. In your mind, you lose the ability to how you're going to shift your attention. I want to focus on this. I want to focus on that, but I can't because I'm so hijacked by this negativistic, making me more depressed, more irritable, more despondent, more anxious, real, that I can't seem to break it. That's a problem with the cognitive function. And then what's happening is Mother Nature's got our brain wired in such a way that our cognitive processes are stitched into the fabric of our emotion. And so the negativistic thoughts are woven tightly with all the negative threads. And then people just can't break it. And no surprise, a lot of people will tell me, you know, the only thing, I just want to get drunk. I want to just smoke drugs. I got to break this. And so that is called rumination. And it's a very common, very debilitating, and very difficult part. A lot of people call it obsessionality. It's not really obsessions, it's called rumination.
To throw another analogy out there, and we can do an old movie. Let's do Hitchcock's Birds. My friend once described the depression he experienced as basically Hitchcock's birds cawing at him at all times. He would try to look up into the sky and it would be Hitchcock's birds. And I think those are the ruminative, toxic, looping thoughts. And when he was able to step out of a depression, it was like the birds went away and he could see the sky again. He could see the world. So I'm curious for your patients, has it been this feeling of really stepping out of your head and getting to be back in the world, getting to even be with people in a way that if you were around others before, you might feel lonely and disconnected?
Well, you know how it feels? It feels impossible to describe when you see people get better in this business. And, you know, I'm a person who likes success, and I want my patients to get better. And I got to say that when someone gets better, the way you're just describing, they don't even need to tell you. You can feel the vibe. Okay,
yeah, the second they walk in.
It's just they're a person. They're so engaged with you, and it's thrilling and it's fun. It's reinforcing. It's what makes it so rewarding. And my hope is that before I'm retired, we'll have that happen 100% of the time. But it happens a lot of the time.
Is there a story of someone in particular that comes to mind?
Well, there's one gentleman in particular that comes to mind right away. It's a story I often tell. This was a gentleman, Eric, that was referred to me. And he had struggled. He was an executive, very high-functioning person, and he had been, ready for this? He had been on over 40 different treatments, okay? Now, you sort of think, well, how many treatments are there? Well, there's a lot. He was on 40 different treatments, ranging from the medications, the talk therapy, electroshock therapy, ECT, so on, we call neuromodulation. And in fact, he even went for deep brain surgery for his depression, right, for neurosurgery. So I think we're going to agree the man had a difficult to treat depression.
Yeah.
And I remember when he got better, and admittedly, no one's going to expect his chances were going to be high, but he got better. And I remember when he came to the office, because I'd only known him as someone who was in agony every visit, and he'd come and the poor guy was in so much agony. I remember when he came to the meeting, and I remember like it happened 5 minutes ago. I came out and saw him in the waiting room, and I could tell like something was just completely different. It was just completely different. It's almost like, it's like when you haven't seen someone for a long time, a friend, and that energy and the emotion that's there, their personhood is right before you. And it's apparent. It's apparent. I've often said that psychiatry is half mathematics and it's half Shakespeare. And you and I are talking about the Shakespeare.
Yeah.
And it comes across. And you say to a friend, I saw a good show. Well, what was good about it? It was a good show. You're talking about the art of it. And that's the art of psychiatry.
Yeah. How did he get better?
Well, he got better with ketamine.
Right.
It was in fact, it was one of the critical moments. I'm sort of a person who is, at some point, if you show me enough pictures that the world is round, I'm going to believe you.
Yeah.
But I'm not going to believe it until I see the pictures first. Okay, I'm not going to sort of be inflexible. But when ketamine first came out, as it was discussed at academic meetings and so on, I mean, is this too good to be true? And I suppose in some respects, I was as guilty as the group think as everybody else, in the sense that I was just used to the mediocre batting average of our current treatments and having to wait 4 to 6 weeks and patients not that happy a lot of the time. Some patients are. Let's be very clear. Let's be very clear. This isn't about the old treatments don't work. They have changed lives. They've saved lives. I've seen many people get back on track with Prozac type drugs. But the fact is, at least 2/3 don't. And we need new options. And so I was skeptical, but again, science is about light bulb moments. And science is about, we're sort of wandering along in this park of unknowing, which is the park of science. And then all of a sudden the light bulb turns on. And that street lamp with the light bulb, whoa, and there's the answer right in front of you. This is a drug we've had since 1962.
Right. We know it's safe.
And we know it's very safe. It's on the World Health Organization's list of essential medicines.
So what are some potential downsides for people that use ketamine medically or esketamine? What are some of the negative side effects we could be looking at here?
Some of the side effects people can get is they can be sedated. They can have what's called dissociation, which means their perceptions are a little off a little bit. It's not that pleasant for people. They can get dizziness, get a bit of nausea, gastrointestinal upset. That can certainly happen. These tend to be transient. They don't tend to be deal breakers. We are very vigilant as to whether ketamine can cause any long-term safety concerns to your heart, your kidney, your bladder, your liver, your brain. Is it causing cognitive impairment? People often say, well, don't ketamine abusers, doesn't it destroy their brain? Well, if you abuse anything in life, it's probably not going to be good for you.
Right. And
if you actually abuse ketamine, let's say as a street party drug, there's evidence to show it can do some damage to your brain. So the obvious question is, if you take ketamine under medical supervision for depression, does it damage your brain? No, it does not do that. It actually, if anything, is protecting your brain. Depression is a cancer to your brain. It's really damaging your brain. And ketamine is protecting the brain. We're not seeing long-term, disturbance in the brain, any kind of toxicology, which of course the FDA is keeping a close eye on through the monitoring systems. People vote with their feet. What's the dropout rate on these drugs for side effects? Less than 1 to 3%, less than 1 to 5%.
Where does psychotherapy fit in here?
Critical. So the evidence shows that if you are taking Prozac for your depression and you got a really difficult to treat depression, adding a psychotherapy to the medication, 1 + 1 = 3. We love that mathematic in psychiatry. 1 + 1. That's why I'm in psychiatry.
So if you're going to be doing ketamine, you can be doing concurrently with therapy.
Yeah.
If anything, that would probably help.
There's a good chance it could. In fact, we're doing a study right now, which CIHR, the Canadian government agency, is funding at our center, looking at whether if we could combine cognitive behavioral therapy, CBT, with ketamine, can that actually rapidly alleviate thoughts of suicide and sustain it longer?
You've warmed up the brain to be more plastic.
I would say, to use another, we're on a metaphor sort of journey here.
It's a lot. Let's pile them all up.
I lost count.
Yeah.
But I think if you took Ozempic for weight loss,
okay,
I think most of us would say, something, you probably would do better if you also changed diet, if you did some exercise, and of course change your lifestyle and so on. I don't think anyone's going to disagree with that. But I think some people, because I know some of these people, are taking Ozempic and they're not changing their lives. I'm not saying that's the right or wrong thing.
Right.
I'm only saying that not everyone needs therapy. But as a guiding principle, I would say that when you add an evidence-based psychotherapy, such as cognitive behavioral therapy, to an IV ketamine, for example, I think you're right. You're the ketamine has primed the plasticity, and then through the psychotherapy, you can begin to really, in fact, really lock in some of those gains, if you will, and maybe also take away tactics that help you cope more effectively, which decreases your vulnerability for future abnormal stress responses.
Okay, last question.
Yeah.
I want to take you back to It was the mid-90s you started out, right?
Mid-90s.
Mid-90s.
Yeah, I graduated, and I started as a psychiatrist in 98.
Okay, 98. From then till now, how much better have we become at being able to target and treat these difficult to treat depressions?
I would say we've made an exciting leap forward, Eric. And I mean, I got to say, if we would have had this conversation 15 years ago. I wrote an article. I don't think anyone read it, so I want to tell you about it. I wrote about 10 years ago. Academics, the biggest delusion academics have is they
everybody reads an article. Yeah.
So I wrote an article, and it wasn't dour. I wasn't trying to be dour about it and negativistic, but I said psychiatry's in a bit of a cul-de-sac right now.
Right.
And I felt that. It was more just a description. I said, we're in a cul-de-sac. We got to think differently. We're kind of we're not going anywhere here. We need new targets. We need new innovation. And so the promise now has come through the innovation. Now we're talking about ketamine. There's been some really exciting advances with neuromodulation, like TMS, transcranial magnetic stimulation. It's really been very interesting how that's advanced. And I won't go through all the details right now. We have over a dozen drug types that are in development in mid to late phase for depression. Didn't even exist 5 years ago.
Right.
That are totally different than the old Prozac type drugs. I think it's not hyperbole. I do not think it's superlative. This is the most exciting, hopeful time for me as someone who's done this now for almost 30 years. This is an incredible time. I've always said that before I leave this business, I want to use the word cure. People said, oh, you're out to lunch. I don't think that's out to lunch. And I think that we're not going to be there in the next 5 years on cure. But I think if we can change the arc of the illness so people can actually say, you know, if I take this intervention, I'm going to stop the illness in its track. It's not going to just progress and destroy my life forever. I can be with my kids, my family, have a fulfilling, good life. That's, in fact, the future of where we're at right now. It is truly a thrilling time in this field.
We're getting better at treating it, but are we getting worse at creating it?
That's a great point. We are never going to have enough mental health care providers.
Right.
So clearly, we need to find a way to decrease, as you're getting at, the start of the problem in the first place. So I don't think you can have a coherent, comprehensive, impactful approach to this scourge called depression until you're approaching this from a public health perspective. Clearly, that's the case. And for those who have experienced depression, we've got a whole new kit of treatments for you. But I like the way you've described it, because I happen to think that the great vaccination against depression is in the public health side. And I'm really concerned about the loneliness pandemic. I think it's a major, major problem for humanity, not just for depression. And that, along with what we're seeing in terms of the hazardous consequence of social media, and again, the insecurities, I described it. These are combustible mixes. And I think that these things obviously need to have political will and advocacy and support. But that has to be part of the conversation.
I did want to finish on this. You are a busy human being. This is wild. I don't know. Maybe I'll get to this camera. I was trying to choose what titles to say in the intro. Right. And this is all of Roger's stuff. I don't know if you can see that. Well, thank you for spending so much time, Roger. I appreciate it. It's always a real joy to be able to hang out and speak with you.
Nice job, Eric. It's been a lot of fun. Thank you.